9:15, so we're going to stay on time. And it's a privilege, pleasure to introduce Dr. David Gordon. We know him as Gordo, affectionately. He is also one of our UMEM alum who, after completing his emergency medicine residency, actually did a resuscitation fellowship. And then at the conclusion of that resuscitation fellowship has rejoined us here at the University of Maryland to complete his critical care fellowship. David's done a tremendous amount in terms of keeping up with the COVID literature, but another area that he has written on and investigated is the utility of lactate. Certainly a question that all of us have in resuscitating critically ill patients. So, Dave, I am very interested to hear what you have to say about lactate, whether we should continue to love it or leave it. Take it away, Gordo.
Hey guys, thanks for that awesome introduction, Dr. Winters. I'm David Gordon, one of the critical care fellows. I'm going to talk today a little bit about lactate and kind of some of its role in investigating what's going on in the body, some of the errors we have in measuring it and how we should probably use it moving forward, as well as some of the ways we probably shouldn't use it that we've already touched on a little bit. No conflicts of interest. And before I get into some of the details about how to use lactate, I think one of the things that's really been lost in terms of how we discuss lactate is the role that lactate plays in our body and how it really comes about to be. So every time we use glucose to make fuel, right, our main fuel for the body, we generate pyruvate via glycolysis. And that pyruvate generally gets transitioned into the electron transport chain to make ATP. But pyruvate gets transitioned to lactate via lactate dehydrogenase. And every time we generate pyruvate, we're going to end up generating lactate. And this is usually in about a 10-to-1 ratio of lactate to pyruvate. So we're always generating lots and lots of lactate. And that lactate is an important fuel for the heart and the brain in times of stress. Certainly, there's evidence that giving hearts lactate when you're in cardiogenic shock will help with improving cardiac output and the brain as well. And about 70% of that lactate is cleared by the liver and 30% is cleared by the kidneys. If you understand this cycle, it has pretty clear implications, which is that generating lactate can happen in a variety of ways. Anything that increases our rate of pyruvate production or decreases our rate of pyruvate utilization or inhibits our ability to eliminate lactate causes an increase in our lactate levels. And that means that our idea of what elevates lactate can't just be limited to hypoperfusion or decreased oxygen delivery. And in truth, there's a lot of things that elevate our lactates. So anything that increases our pyruvate production, like we said, like increased catecholamines or seizures, sodium azides, shock, sepsis, cancer, pheochromocytoma, or anything that inhibits our ability to use pyruvate, like a thiamine deficiency, cyanide, metformin, can all inhibit or can all increase our lactate levels, as well as anything that increases our or decreases our ability to eliminate lactate, right? Like liver disease or Tylenol toxicity. All of those things can increase our lactate. And this differential comes from a couple of different articles, one of which was published earlier this year by Wardy et al., about all these different things that can cause elevated lactates. And you can see that decreased oxygen delivery is only one thing that can do that. And with this context in mind of how lactate is generated and the role it plays in the body, we can come to our objectives, which is addressing whether or not lactate should be a marker of hypoperfusion and sepsis. Should lactate be something that triggers our fluid resuscitation? Can we use our labs and how trustworthy should they be to evaluate our lactate levels? And finally, lactate is a prognostic marker and how we should use it in our evaluation and treatment of patients. So if we go all the way back to 1843, this is one of our first descriptions of lactate in the settings of clinical medicine. And this is by Scherer. This is from his book, The Chemical and Microscopic Investigations of Pathology Carried Out at Julius Clinic at Würzburg. And one of his chapters goes on to describe several pregnant women one of which unfortunately succumbed to a group A septicemia postpartum, and another who developed HELLP syndrome type disease and who also went to go on to pass away postpartum. And both of them had elevated lactates on their autopsies. This prompted a lot of investigation into lactate, and eventually it was found that lactate was associated with a wide variety of conditions, such as liquid and solid tumors, bloodletting, pernicious anemia, CHF, COPD, and a variety of other inflammatory and infectious conditions. It's not until several years later where Fletcher and Hopkins evaluated lactate in frog muscle. And what they found was that in frog muscle, when it was worked out in anaerobic conditions, it generated a lot of lactate. And when that muscle was exercised in aerobic conditions, it didn't generate as much lactate, or about the same as much as it did in room air. Now, the issue with lactate, and that it's an issue of hypoperfusion, has been propagated by the Surviving Sepsis campaign in almost every iteration of their Surviving Sepsis campaign guidelines. And in the most recent one, I do give them credit that they allow for that elevated lactate could be from several other reasons, and that's important to acknowledge. And it's important to acknowledge because lactate isn't necessarily hypoperfusion in the setting of sepsis. As you can see, lactate is generated at a wide variety of oxygen deliveries, and there's not a clear correlation between decreased oxygen delivery and the amount of lactate that we generate. And that's because in sepsis, one of the most important mechanisms that we use or one of the most important mechanisms that causes the elevation in lactate is that mechanism of increased glycolysis and pyruvate generation from epinephrine. So epinephrine stimulates our beta agonism, and this activates our cyclic AMP. And overall, we get more pyruvate metabolism. And the more pyruvate we get, like we said, the more lactate that we generate. We can evaluate this experimentally. So this was done by Levy et al. In 2008, and they took several different rat models, and they generated 3 types of pathophysiology: an endotoxin model, a hemorrhage model, and a peritonitis model. And as you can see, in every one of these models, they had an increase in their level of epinephrine. To go along with that level of epinephrine in all of these models, there was a concomitant increase in lactate. Now, in the hemorrhage and peritonitis model, and especially not surprising in the hemorrhage model, blood flow plummeted. But in the endotoxin model, the blood flow increased. And I know that Dr. Greenwood touched on this a little bit earlier. This may not be an issue of macrocirculation and hypoperfusion at the level of macrocirculation, but there's certainly evidence here that our blood flow increases in the setting of sepsis, and so that this is at a time of high cardiac output. So giving fluids to increase the cardiac output may not be a part of what's going on, but the blood flow here increases. If we take this one step further to further kind of characterize our mechanism, we can look at what happens when we block various places on the pathway. So this is each one of those models, and the circles are where the model with no intervention. But those 3 lines below it are all very closely grouped together. And those are blockage of either beta blockade, beta 2 agonism, or specifically blockage of the sodium-potassium pump. And you can see that each one of those causes the same reduction in the production of lactate, which is an indication that this is likely the pathway, or a large part of the pathway, for what's generating lactate in these models. But we can go beyond this and look at human models. And here we have a study from 2009 from Woodbridge et al., where we look at the provision of epinephrine to patients who are in septic shock. And we check lactate at the beginning, and it's 4, and checked it 4 hours later, and it's almost doubled. And this was associated with an increase in potassium. And this really held true for those patients that survived. And I think this means that if we give these patients catecholamines, we'll see the elevations in lactate that we expect, tying together the idea that lactate generation is closely associated with the amount of catecholamines that we generate. And so I think we can kind of put this idea to bed, or at least give it some secondary status to other ideas that lactate is a marker of hypoperfusion in sepsis. Now, if we go beyond that, we can ask ourselves, well, what should we do, kind of as Dr. Greenwood was saying before, with lactate in the setting of sepsis? So in 2001, we have the early goal-directed therapy for sepsis, which was a really interesting trial where they had a whole bunch of markers to try to improve the delivery of oxygen to the patients who were septic. And this is where we get our 20 to 30 mLs per kg bolus for patients that are in septic shock. And this idea really got pushed and propagated again, that every time we see lactate, we give fluids. And that's how we've ended up with this, which is a very strong lactobolo reflex. And I think we all know that this is something that we do both within ourselves, and we've seen our colleagues do it. And now, having had the opportunity to go practice at a couple different places and in a few different arenas, both in the ED and the ICU and a variety of ICUs, this is something that I see over and over and over again that is reflexive. Lactate is elevated, we need to give fluids. And like I said, I think we know this ourselves, but it's also been shown experimentally. So this is a study from 2010 where patients were randomized to either lactate-guided therapy, where lactates were trended every 2 hours, versus where physicians were blinded to those lactate levels. And the goal, of course, was to have lactate decrease by 20% every couple hours. And there's a couple of important things to note from this study. One, the lactate group got more vasodilators, which I think is interesting, but also the lactate group got more fluids. Now, this would be fine if fluids were a benign treatment, but unfortunately, we've come to find that they aren't. And we've seen that the more fluid, the higher patient's fluid balance, the worse they do, especially in the first couple days of their hospitalization. And as the place where lots of patients enter the hospital, where we give a lot of the initial fluid resuscitation, it's important for us to keep this in mind and to do this as responsibly as possible. Now, I know Dr. Greenwood already touched on this, but I feel like it wouldn't be a critical care lecture if we didn't talk about Andromeda shock, where we really evaluated, well, what happens if we use lactate as our trigger to evaluate for various interventions, including fluid resuscitation. And in this trial, when the goal was to have the lactate decrease by 20% every 2 hours versus having our capillary refill checked every 30 minutes. And if our capillary refill wasn't normal, patients would get fluids. And I think this is important because one, ties in lactate as a marker of perfusion, and two, ties in the provision of fluids to elevated lactates. And what did we find? Well, just like Dr. Greenwood said, patients in the capillary refill group got less fluids, their SOFA scores were lower, and their 28-day mortality just barely missed significance, but was markedly lower than those in the lactate-guided group. There was no difference in the groups between mechanical ventilation-free days, renal replacement therapy, vasopressor-free days, or other markers of mortality. But this does, A, verify our lactobolo reflex, but also shows us that maybe that's not the best approach to managing our patients. And so I don't think we should use lactate as a trigger or a marker for our fluid resuscitation, especially in the setting of sepsis. Now, what about tourniquet use? What about looking at labs and lactate? So I think this is important because understanding how it is that we get our lactate levels and how we use should affect how we can use that information. And so I think there's a couple times where we've all had elevated lactate and said, oh, it's from tourniquets, oh, it's from this. And so I think those are important things for us to address. So this was a study done in the ED where it looked at 40 patients. And I think this is a really nice trial because it was very pragmatic in their approach. So they looked at 40 patients who had lactate drawn in the ED. They didn't look at any trauma patients. And they measured two lactates. One was a lactate that they obtained in the normal course of getting basic labs, so including a tourniquet. And the other was a lactate drawn without a tourniquet to make sure that that wouldn't interfere with the lactate levels. So in those 40 patients, the mean lactate in this group was 1.9, and their average time between the two was roughly 6 minutes apart. And as you can see, the two correlate extremely well in a one-to-one basis. I don't know how well this applies at much higher lactate levels, but you can see that it applies very well at the lower lactate levels. What about lactate and time? So the first is a study where they looked at 80 patients who were divided into 3 groups, one with no tourniquet at -1 degree Celsius, one at no tourniquet at room temperature, and one with a removable tourniquet. And this is important for a couple of different reasons. One, besides the tourniquet use, is the difference in temperature. So when we keep lactates or these blood samples cooler, we stop the glycolytic process that goes on in the cells that we have in those tubes, both in our red blood cells and our white blood cells. And so if we can stop that, that will inhibit the ability of those cells to continue to generate lactate while they're in the test tube. And we can see that over the first 15 minutes, that effect is pretty minimal. And that in those groups, the cold groups had almost no increase in their lactate. And in group 2, the ones that were kept at room temperature over the first 15 minutes, 4 out of those 21 had an increase of 50% or more in their lactate level. But overall, across the entire group, there wasn't any difference no significant difference in terms of their initial and later lactate levels. However, when we look over time at the next graph, we can see that beyond those 15 minutes, those elevations in lactate are more pronounced, especially in the room temperature group, that top graph. You can see that slope is much higher than the lower graph, indicating that over time, those elevations in lactate progress more quickly and to a more extreme degree in the room temperature group than in the cooler group. They also found something interesting in this study, that it was very related to the amount of white cells in the blood, which, as you can imagine, is pretty important in the setting of sepsis. But what about an arterial versus venous lactate? So this was a study done this year, and this has been a pretty ongoing point of contention. There's a really nice systematic review we'll talk about in a second where they discuss a lot of this evidence. And they point out that they evaluated 100 patients with septic shock from an A line and a central line. And their initial lactates were both high and different, but not that different. 3.0 for the arterial lactate and 3.7 for the venous lactate, which is different than some of the other data that's been published before. But they still published pretty well that higher lactates were higher and lower lactates were lower. Now, when they evaluated those same patients again at 6 hours for lactate clearance, they found even more improvement where the lactates were lower. And so I think this is important because what it tells us is that at higher lactates, these numbers may diverge more so than at the lower lactate levels. I don't know how much this matters because I think at the end of the day, kind of a high lactate is a high lactate and should make us concerned, versus a low lactate being a low lactate, and maybe that should make us feel better. And that number that maybe should make us feel better is the number 2. So 2 millimoles per liter seems to be the level where we have really good agreement. So lactate levels that are less, a venous lactate level that's less than 2 is somewhere between 97 and 100% sensitive for having an arterial lactate of less than 2. And so when the venous lactate is low, you can assume that your arterial lactate is going to be low. As they get higher, those numbers will get more divergent. But again, I'm not sure how much that really matters because a high lactate is a high lactate and a low lactate is a low lactate. And this might only be important as we evaluate the lactates over time. So one of the things we've all, of course, learned as well is the mud piles mnemonic. And right, all these things, including lactates, should cause an elevated anion gap. So even in patients that we're not that concerned about, or we may be on the fence about whether or not to order a lactate, can we just look at the anion gap and let that make us feel better that they probably don't have an elevated lactate? And unfortunately, that is probably not accurate. So this is 272 lactate measurements of patients in the ED, including those with DKA. And they looked at the standard anion gap cutoff of 12. And they found that it was not especially sensitive or specific or accurate for finding an elevated lactate. Now, when they look at an anion gap of greater than 6, that was, of course, much more sensitive. So you found lots and lots of elevated lactate, but that was even less accurate with 32% for evaluating and finding patients that have elevated lactates. So I don't think anion gap is a good screen either. Now, the whole reason I really wanted to have this section was to talk about something I learned this year, which is the lactate gap. This is really important when it comes to certain causes of elevated lactate, specifically ethylene glycol. And I think it drives home two important points. One is both about the lactate gap, but two, about understanding some of the ins and outs of the different techniques and methods that we use to get our lab values and we use to evaluate patients. So a lot of the point of care lactate modules will use glycolate or measure lactate, and they often can get glycolate confused for lactate. And the issue is that glycolate is a metabolic breakdown product of ethylene glycol. And so as you have ethylene glycol break down, your glycolate goes up. And so you'll have this huge lactate on your point of care measuring devices that isn't reflected on your serum lactate that you get when you get it from the lab. And this should be a clue or a trigger that we need to reevaluate what we think is going on and to possibly evaluate them for ethylene glycol poisoning. So can lab error cause a high lactate? I don't know. Lab error is probably a strong word, but certainly how we measure a lactate, how we go about getting that value influences or can influence what that specific number is. Does that specific number matter? I don't know, but I think that understanding how we get it is important. So I think this all brings us back to this this pathway that we had at the beginning, which is understanding that there's lots and lots of different things that can cause elevated lactates. And I think we can talk about a couple of them. Obviously, we're not going to go through all of them, but we'll talk about one or two or some of them. And I think it's important to keep in mind this quote. When I was an intern, we got a lecture from Judd Hollander who said, any troponin is worse than no troponin, and more troponin is worse than less troponin. And I think the same thing can be said of lactate, that any lactate is worse than no lactate, and more lactate is worse than less lactate. And that's certainly true in the emergency department. So the first graph is from Heidel et al., where they looked at 5,000 patients who presented to the emergency department. And they showed that an initial lactate is correlated with a poor outcome at a variety of levels. And the higher the lactate is, the worse the 10-day mortality, right? So at 8+, that 10-day mortality is almost 50%. It doesn't break down just simply linearly, right? As we can break our lactate into groups, and at increasing levels of lactate, we see a same increase in mortality. Not only that, we see that it is worse for patients who have infections versus those that don't. And this is in patients that have that are already pretty sick coming in, right? They have high shock indexes, they have a high heart rate, they're tachypnic, they're hypotensive, or they have they're pretty sick. And this was across all comers in that second graph. If we look specifically at septic patients or patients with a concern for infection, we can look and see, do we see a specific cutoff? And the initial lactate is probably associated with worse outcomes in sepsis, and we see that across a number of studies. So the first graph is from 1,865 patients from the MARC database, and they found the lactate cutoff of 3.25 or 3.225 had the best area under the curve operator statistics for predicting all sorts of different types of mortality: 30-day mortality, 90-day mortality, hospital mortality, and 1-year mortality. We also see that lactates can be used to look at other things, right? So lactate hasn't just been studied as binary, but it's several other things can cause, or several other ways we can break down lactate levels. So this is for looking at 28-day mortality in 1,278 patients admitted from the ED. And as lactate went up, so did mortality. And this didn't even look at patients who were necessarily hemodynamically unstable or had SIRS. This was just all comers for patients with infection that had increased mortality. But we've talked about there's lots of conditions that we can see elevations in lactate. So we can see elevations in lactate and trauma as well. So this is looking at 500 or 281 patients that had lactate measured at 0, 2, and 4 hours. And there's some bias in this, but higher lactate levels were associated with increased mortality, and less lactate clearance was also associated with increased mortality. In patients with really high lactates, it didn't add much, and in those who were normotensive, the lactates or the lactate clearance didn't add a lot either. And about half of these patients had elevated lactates on admission, but there's a pretty clear indication here, right there, pretty clear signal here that elevated lactates have an increase in mortality. It goes beyond mortality, though. They have higher injury severity, more ICU admission, longer hospital length of stay, more organ failure, more respiratory issues, more blood loss or need for blood products, more chemical support, or more need for the operating room. We can also find lactates in places that we don't expect, one of which being subarachnoid hemorrhages. So this was a retrospective study of almost 250 patients with aneurysmal subarachnoid hemorrhages in the emergency department, and they had a mortality of 21.5%. The lactate in the deceased group was significantly higher, 3.5, versus 2.5 in the group that survived. Now, there's a lot of things that could go on here, right? This is a retrospective study. Sicker patients probably, who looked worse got lactates. But nonetheless, we can see this worse mortality, or these patients who were at higher risk had higher lactates. And it's important, especially in these patients, right, because they're known for developing or have the potential to develop flash pulmonary edema, and giving them fluids is probably not the most important thing. And here, the most likely cause is probably related to the physiologic stress of the body. One final etiology of lactate that I want to discuss a little bit is that related to metformin. So metformin overdose, right, probably has to do with not only is there less glucose, but this provides some not only is there a problem with glucose metabolism, but it inhibits the ability of the mitochondria to produce ATP, and therefore we get more lactate. And you think that in a disease where we see lactates as clearly part of the pathophysiology of the disease, that lactates or a higher lactate would be associated with a higher mortality. Now, some of the data on this has gone back and forth a little bit, but in this particular study, in 56 patients, a higher lactate was not associated with an increase in mortality. And one of the reasons that this is important, right, and I'll get to in a second, is the idea of source control and understanding how we have to treat different things. And so the most important thing whenever we find a lactate is to evaluate what is the source. So what is my personal approach to an elevated lactate when I find one in the ICU or the emergency department? So if I have a lactate greater than 2, or I'm not seeing lactates get better, I think we need to evaluate the patient, right? Obviously, we need to do our ABCs. We have to be careful about intubating patients with a severe metabolic acidosis. I think at first you need to come to the bedside and do a really brief exam, a physical exam on the patient to get some idea of their physiology. Is the patient warm or are they cool? What's their capillary refill? We can use an ultrasound to evaluate their physiology. And now in 2 lectures out of the 3 lectures, all pertaining to this particular topic, we've talked about evaluating capillary refill, which is, I think, a really important part of our exam. And then this can help us clue into obvious cardiogenic shock, obvious trauma, different signs of infections, or different signs of ischemia, right? If we do our ultrasound and we see a really flat IVC and an empty heart, that may be an indication that they need fluids. If we find obvious trauma or obvious intra-abdominal fluid, that may be a sign of trauma, or maybe they just have a clear infection or a cool limb or pain out of proportion on their exam, right? Those would all be signs of we probably know where their lactate's coming from. If we don't have anything obvious there, then we can go on to look for our more detailed history and physical and really look for any clear exposures, right? Do they take metformin? Do they have any signs of soot that might be an indication for carbon monoxide exposure? Do they have, did they take a lot of Tylenol for any particular reason, right? All these would be really helpful to know. And if we don't have any other answers there, we can use our labs and imaging to find other signs of infection, ischemia, or different toxins. And then we're going to intervene. Whatever our issue is, we're going to go and try to get source control. That's important in something like metformin because the issue of source control you may think is something like CRRT, but getting tox involved and finding out that it's actually IHD is pretty important in terms of helping with your clearance. And then we're going to reevaluate. Did our lactate go down? Did our patient get better? What's their capillary refill? What's their exam? And that cycle will continue until the patients get better, or hopefully get better. So with that, do you guys have any questions?
Thanks, Gordo. That was outstanding. There are a few questions that I'd like to pose from you from the group coming in through the live stream.
Sure.
What are your thoughts on, if trending them, if following them, serum lactate versus whole blood or point of care lactate? Is there any difference in those two values?
So I can't necessarily give you an exact specific answer, but I think if you're going to be trending them, you should probably try to trend the same thing consistently, right? So, we looked at venous lactate versus arterial lactate, and we talked about the point of care lactates, and understanding that these are going to be potentially have some different characteristics in how they got measured. We should probably be trending the same thing throughout the course until at least we know how they correlate.
Great. And then in terms of the frequency, one of our questions came in. Currently, we follow it here every 3 hours in our emergency department sepsis resuscitation. Is there an optimal time frame? Understanding there's many different etiologies of its increase, but in the setting of true hypoperfusion and you're trending this, do you have an optimal time frame for repeating it?
I guess, I grew up in our emergency department, so I'm really used to the 3 hour time mark. But I don't know that there's a great answer. And one of the issues is that these, the percentage that it drops and the timeline over which it drops is really variable over a lot of different studies. I think in my time in the emergency department, certainly seeing something drop over the first couple hours, that's what they looked at in the Janssen study. That's what they looked at in Andromeda shock, which are, really true. I think see an elevated, or especially the Andromeda shock trial, see an elevated lactate and reevaluate it. I think seeing it get better in that kind of time frame with your intervention is really reassuring. But certainly in different etiologies, seeing it get better over longer periods of time is also really reassuring. So I think I personally tend to use the 3 hour time mark, but I think the most important thing, more important than necessarily trending them, is seeing your patient get better, but also knowing that you're using your lactate as your trigger for what is the source for what's happening.
Great. And last question, in terms of all of the things that you've talked about, is it really fair to use lactate in the definition of septic shock? And one of our listeners wanted to know what your thoughts are on that.
So I think if you define, if you're going to use lactate as your definition for organ hypoperfusion, I'm not sure, and say, well, shock is really that we are hypoperfused and we have decreased oxygen delivery, and that's what we need, and that's how we're going to define shock, and that's what shock is. I don't think that lactate necessarily tells you that. But I'm not sure that that really fits necessarily with the spirit of what we're doing when we're defining shock and we're trying to define who's really ill. And lactate has been shown repeatedly at a variety of levels over and over and over again that to predict who is sick and who's going to do poorly. And I think a lot of what the Surviving Sepsis campaign and evaluation for shock or evaluation for septic shock is picking out and understanding who's really sick. And if your goal is to figure out who's sick, then using lactate, I think, is an excellent marker for helping you define what I like to say is badness, or who's really sick.
Great. Do you have any final take-home points or summary statements for us before we switch over to Dr. Chang?
Sure, I have two things. So one, just to go back through our objectives, lactate is not a marker of hypoperfusion and sepsis, and certainly if there is hypoperfusion, it's not the whole story. Two, I'm not sure that lactate should not be our trigger for fluid resuscitation. I think this is potentially something that could be more harm than good. We have to understand, though, we should love it, using lactate to evaluate or understanding how we evaluate our lactates and what they mean, and we should use them as a prognostic indicator. And lastly, I just want to point out there's a few really good sources on lactate if you're really curious. This Kraut article from 2014 is an excellent summary. Garcia Alvarez is a great summary for sepsis and lactate. The lactobolo reflex is a great article from the Journal of Thoracic Disease. And then the Wardy article of demystifying lactate in the emergency department is a nice summary where they can go over, where they go in depth about some other certain things. So that's what I have. Thank you guys so much.
Thanks so much, Gordo. Great deep dive on lactate in terms of our resuscitation.